kick off. So my name's Nick Van ter Hayden. I'm an emergency room physician and have my own company called Incremental Healthcare. And I am the orchestrator, the technology behind all of these sessions. So thanks to everybody for joining us. A few sort of points so that everybody is familiar with this. This session is being recorded and will be posted online. I can edit it, and if there's any reason to do so, but it's really for the purposes of sharing as much of the information as possible. But I let everybody know because I live in a two-party recording state, so I've now satisfied that requirement. I would also tell you that the chat, even if it's private, between you and another individual, does get recorded in the way that Zoom works, at least I think so. So please consider chat essentially public, and you know, keep it appropriate in terms of content and style and so forth. For questions and subsequently we'll hold off and allow our presenters to present their content and hold questions, but please use the chat section to ask questions. We'll try and bring people in. If you don't want to ask yourself, you can just put it in, or you can raise your hand. I will try and call people and allow you to ask questions subsequently. All I would ask is that you keep yourself on mute when you're not talking. It can just be a little bit distracting. And if I do identify people, because I can see it in my control panel, I will mute you. I think you can unmute yourself. I don't have sort of total control, and I try not to be sort of edict, but I want to be respectful of those people that are talking. And, you know, feel free to reach out to me. Otherwise, that's the basics. Jim, over to you, and introduce the session.
Okay, well, good afternoon, everybody. Thanks for joining us. And again, thanks, Nick, for all your work arranging this and with the logistics and all of that stuff. I'm going to turn this over to Richard Singerman in just a moment to introduce the topic and our speakers. But I first want to do two things. I want to extend apologies from David Main. David is attending virtually a Winston Health Policy Fellowship Board meeting at this very time, and for some reason thought that that took precedence over Health Tech Net. I can't imagine why, but I invite you to harass David at your leisure when you either see him or communicate with him next, but he did send his apologies. I also want to give you a brief preview of next month's topic, which will be on social determinants of health with a tilt towards the uneven effects of the pandemic on various socioeconomic groups, that sort of thing. And Suniti Pangshe and Deanne Kasim are putting that together. I think it should be really interesting. I personally am beginning to long for the time that the pandemic is not uppermost in everybody's mind. So I'm looking forward to that day. But until then, that continues to be the kind of the unifying theme between every program we've been doing now for months, and particularly this one, which I think is going to be fascinating. I'm going to steal one quote from Richard Singerman when we talked about this last month, and he said, "It's better to be lucky than good." And to have thought up this topic and arranged this topic several months ago, I think turned out to be almost clairvoyant on our part. So Richard, thank you so much for suggesting the topic, for leading the effort to put this presentation together, and for the work you did with Dr. Furlong and with Craig putting it together. So Richard, over to you.
Great, thanks, Jim. Just a couple of things. First of all, as far as the topic, I wish my stock picking was as clairvoyant as my speaker topics. And I think we should make David Main watch the whole Zoom video and give him a quiz.
Absolutely, absolutely.
Okay, so very good. Well, on that note, first of all, I really want to thank our speakers, so I'll give a quick intro to in a moment. The topic for today is on real-time health system emergency preparedness. And really, this came out of the fact that many of you know I'm bi-coastal. I spent part of my time in California and LA, part of my time here. And in the Wall Street Journal in September, an article came up about local hospitals in Southern California where patients were presenting with COVID or were maybe going to be in an ambulance and go to a hospital and the hospital said, well, we're on divert, which means we can't take anybody. And there are literally stories of people getting shuttled around for hours, 2 hours, 3 hours away from their home to get to an emergency room. And obviously, whereas COVID has put this front and center on our minds, you know, unfortunately, this will not be the last major disaster. And, you know, in terms of the Washington, D.C. area, we know we think about this probably more than other places. So we're probably a little bit more prepared. But certainly, hopefully, out of today, we'll try and get a sense of lessons learned so far, what are best practices going forward, especially on the tricky issues that this involves. What does it mean for a hospital bed to be licensed and available? What's the real nitty gritty of that? What are the staffing requirements for it? What does this mean when, you know, usually, you know, MedStar and Hopkins, you know, we all want to do great work for patients, but they're competing health systems. And usually bed availability is something pretty proprietary. So, but we have to share, in this case, for the benefit of the community. So these are some issues that really brought forth this topic. So we have two speakers today. Craig Behm, who's presented about 6 or 8 months ago, is the Maryland Executive Director for the Health Information Exchange at CRISP, for the Chesapeake region and for DC. And Brendan Furlong is the VP of Operations and the CMIO for MedStar, and he's also on the board and actually is actually the board chair of CRISP for Washington, D.C. And so they're going to be going off of one presentation, which they're going to tag team on. Craig's going to get into a lot of the technology issues. Brendan's going to approach things from the clinical side. Brendan, Craig, with that, I'll let you guys take it away, and hopefully I was okay on your backgrounds and descriptions, and we're really thrilled to have you and look forward to but each of you presenting for about a half hour and then having about a half hour of really strong Q&A. So with that, take it away. I'm going to mute myself and go off video.
Great. Thank you. Welcome, everybody. Can you see my screen okay? Perfect. Well, we really appreciate the chance to be here. As Richard just said, I'm going to go through, you know, a tiny bit about CRISP, and maybe most importantly, just talk about the kind of infrastructure that I think allows for a lot of the work that we're doing. But then Dr. Furlong's really going to talk about the nitty gritty, you know, aspects of the response, especially from a healthcare and health system perspective. So as a quick refresher, CRISP is the state designated health information exchange for Maryland. I am the point person for Maryland, so that tends to be my focal point, but we're also the designated exchange in the district, and pretty much everything that we're doing in Maryland translates in some form or another to DC. There are some minor differences in kind of the way we interact with our different health departments and some of the data available. DC, I'm still angry at my colleague, Ryan Bramble, the executive director there, who has led data and is doing a lot with school absenteeism. We have not cracked that nut in Maryland, but Maryland has a unique hospital payment system, which has given us some kind of interesting claims insights, and we do work with global budgets. So maybe it's even. Something about CRISP that I think really, maybe this was part of Jim's intro, is probably really important, is that everything we do requires cooperation and collaboration. Aside from the technology, we really pride ourselves on the capabilities to bring people together, to be a neutral kind of convener. And we do not do projects that only happen through one single health system or one single entity. The whole point of an HIE is to work across different groups. Oh, and maybe I don't have any stats on the data we share, but you know, we're connected to all the hospitals in the region. We also support West Virginia. We've recently started doing work in other states as well. And so we're pushing about 1 million encounter notifications per week out to primary care doctors and payers and other interested groups. We have our in-context application, which is based on FHIR, and that's queried about 100,000 times per week. We have a user portal that physicians log into that's accessed probably another 80,000 times per week. And there's just immense volumes of data flowing through our secure infrastructure. With that, Dr. Furlong, do you want to give an overview of MedStar?
Sure, and thank you all for having me as well. So MedStar Health is, as if you don't know, is really one of the biggest health systems in the region. We see in MedStar approximately 25% of all patients in Maryland and DC. So a very large chunk of the folks in our community get their care with us. We have 10 hospitals and a comprehensive network of outpatient centers, urgent cares, and physician offices, about 300 front doors MedStar has across the region. So fairly large. And with that size comes, both the duty and a responsibility to step up when things like pandemics happen. We have about 31,000 folks who work with us, 8,700 nurses, over 4,000 doctors, of which, more than half are, about half are employed, I'm sorry. The other thing that's very near and dear to my heart as well is that we have a very strong educational mission. We have 1,100 residents and fellows, which puts us in the top 10 in the country in terms of academic residency training and fellowship training. We have insurance plans. We have MedStar Family Choice, and so we have folks who are primarily responsible for all aspects of their care. And then, of course, we have our academic affiliation with Georgetown University, where we teach medical students, teach in the medical school, and perform research and in collaboration with what we call the MedStar Health Research Institute. So a fairly good size chunk in our community here. And again, like I said, with that comes a responsibility to be ready whenever things like this happen. So I was, without being sort of all over the place, I was trying to think of what would be useful for a group like this. And again, my hope is that you'll direct me to things that are interesting for you. But as I was thinking about our approach to data in the pandemic, and I guess probably worth just a moment in background for me of who I am. And so I'm not a computer scientist. I am the worst technical person in all of MedStar, probably. I literally have to hand my iPhone to my kids at least once a week to get it fixed. And apparently you're just supposed to turn it off and turn it on. So with that, what I do bring to the table, though, is an appreciation for the power of data and how it can help us do a better job in caring for patients in the moment and then in aggregate. And the complexity of the systems and helping to implement and manage those things has been a part of my career for many, many years. I came to Washington in 1995, worked at Prince George's Hospital for 1 year, and then went to the Hospital Center, which is the biggest hospital in DC, in 1996. And when MedStar formed and Georgetown joined, I came over to Georgetown here in 2000. I've been chief of emergency medicine at Georgetown for 16 years and just passed that baton in August of this year to one of my mentees. And I raised that and I work clinically. I work clinically. I work last evening here in the ER. And so I think what I bring to the table in this is without being dramatic, real life use of this. This is not theoretical to me. This is what I do when I'm working. And in light of that, it helps us, as a team, have clarity as what we're trying to get out of data, help define it, hopefully accurately, and be ready to change as it changes. I would definitely say that, the early part of this pandemic, we were very focused on, just what's going on here, and we hadn't, we didn't have tests. We had all kinds of new things coming at us. And so that which mattered was extremely dynamic in the early of this. And yet you're able to ultimately come together and really sort through those things that matter the most. Critical to this are aggregating tools, whether that's within a system. We use those at multiple data layers within our computer systems. We ultimately have in MedStar, we use Health Catalyst as our primary data warehouse, but we have many, many feeding systems that are quite important to that. We have to reconcile our definitions very, very quickly across those data systems and among clinicians to make sure that we're all speaking about the same thing and that we can then measure accurately. We have to figure out what elements matter the most. It may not be intuitive to you who are not clinicians that COVID-19 positive is a number, but patient under investigation is a really important number as well, because it's a driver, so that if I'm caring for a patient in the ER or we are in the hospital, if somebody's COVID positive, then we have all kinds of precautions we take. We have all kinds of, PPE that we use. We have ways of placing them in different parts of the hospital, et cetera. But if you think about it, if somebody's under investigation, meaning a test is pending and we have a clinical suspicion, we have to treat them essentially the same way. And so, yes, they're different, but there are many things that are driven that we have to sort of reconcile, that there are parts of this are the same, there are parts that are different, and then again, become facile at measuring these things over time. At MedStar Health, our primary EHR is a Cerner system. We call it MedConnect. But then we have other systems that we need to use our aggregating tools to bring together. And so those are things like teletracking, and that's a primary capacity management system, which basically tracks the beds in hospitals. In addition, we have a Siemens, which is our primary reg-skeg system, and that's on the inpatient side. In addition, I didn't put it on this slide, but we use what used to be GE, but is now Athena IDX as an outpatient registration system. And then we have manual elements. There are areas of data that we have to put in, some that are difficult, that are so dynamic that they're difficult to have sitting reliably in a data system. And sometimes, those can be around some of our staffing, even though we have, staffing models and we have computer programs that are managing it, that things change on the moment. The nurse gets sick and they need to go home, or things like that. Those are all elements that we have to be accounting for to be able to accurately portray where are we in terms of our overall capacity management, for instance. It's very important for us to trend this over time. The daily trending is really important. And some things we need to know even in more real time. And so, for instance, emergency department volume across our system is something we need to know all the time. How many patients are admitted, how many are boarding, where are they? Yet other numbers do lend themselves to daily trending when we're looking at aggregated number of, patients in all of our hospitals that have COVID positivity, how many of them are in the ICU, how many are on a ventilator, how many beds do we have? All of those pieces, those things can themselves in terms of our overall planning to daily trending. What's important also is that I think that what we also have to realize is that our key decision makers, we need to produce data for them that is very, very digestible. And so we use display tools like Tableau, like that, to make it so that you can see as a looking at tables and numbers, that you really have to form that. And for some of our audiences of data production, it's a matter of creating a static report where you say, here's the daily report, and that is what those folks are good at looking at. They help us arrive at what they want to see in those reports. And then there's another group of people who are maybe a bit more tech savvy, who would like to have something that's live, something like in Tableau, where you can filter for the question of the moment and things of that sort. So we really have to make sure that when we're producing the data, that we know who our audience is and how they best receive it, how they best digest it. It can be critical in the moment to distribution of patients across our system. And again, I'm speaking a little bit MedStar-centric, but imagine that we have been cooperating clearly via CRISP and other mechanisms with the Department of Health in Maryland and the Department of Health in DC to make sure that we are not just acting alone. But within a system, every day we look at our capacity and we look at where we need to move patients so that we know that in this pandemic that it has been extremely variable among our 10 hospitals. We have a fairly big geography. We're all the way down to St. Mary's, at the tip of St. Mary's County, up to north of Baltimore. And this pandemic has shown itself to have hotspots that have differed over different parts of it. Early on, Prince George's County and Southern Maryland Hospital and Washington Hospital Center, those are or places were the busiest ones that were sort of in the neighborhood where patients were presenting early. When we had the surge that happened again in the November timeframe, it was much heavier in Baltimore to begin with. And so knowing where those patients are presenting in the ER, where we are with the capacity across the system, allowed us to actually transfer patients among our facilities to really create effectively one giant MedStar hospital, which was 10. And that was one of those really, really great areas where everybody knew it's supposed to be that way. The pandemic really helped us push forward. Every day we would get together, and at first we started with just manual reporting of our capacity at each facility, and we would do it a couple times a day. We would get together in the morning, get together in the afternoon, and we would go through these items and make a plan for the next 12 hours at a time. But then it became apparent that for efficiency, how much of this could we automate and do so? And that's a huge body of work that took place during the last 10 months or so here. It's important for the moment, but it's also really important as we think of things like our supply chain and using predictive analytics. As you can imagine, you've heard, really rough tales across the country of folks worrying about not having enough PPE, not having the right kind of masks, things like that. We were incredibly lucky at MedStar Health to never be wanting for any of that. We were very careful. We were very cautious. We were thoughtful about how we used the equipment and how we used the personal protective devices. We were never short on ventilators. We never had any of those problems. And part of that I would bring back to a group like that is because we had good data and we could see what we were using. We could see a surge starting to happen by ED volume, and we could anticipate that in our supply chain and aggregate and bring together and acquire, more, PPE that we would be anticipating needing. And we also were able to look at it and also look at spots where how efficiently we're using all that equipment, meaning that you might have a surge and you'd expect a rate of, I'll call it the burn rate of our PPE to go up. But then maybe you had some places where you're saying, hey, wait a minute, the volume's very low, but we seem to be consuming a lot of PPE. Let's figure out what's going on. Is there something special about that patient population? Is there something going on in the variability in how we use that equipment in our system? And so we really, used this data in many, many ways, not just for the moment, but to actually plan and anticipate ahead of time, what we are going to be needing as we're in the peaks and the troughs and then back to the peaks of the pandemic. Next slide.
I think we are going to bounce around a little bit.
Yep, absolutely. So flipping over, I think it's important, and I sort of throw that out there, and I know we're going to have Q&A at the end, but definitely, these are just considerations, a few sort of random thoughts, and I would love to hear when the time is right from all of you what your thoughts and ideas could be. Thanks, Craig.
Great, thanks, Dr. Furlong. And I think there's a really clear thread here where the health systems, MedStar is a prime example, are managing the data, the infrastructure, and obviously doing the direct patient care kind of as their own systems. And then where the HIE is unique is that we can connect across systems with the health departments to raise the same types of decision making on a macro level. One of the tricks that we're trying to wrestle with, I think, all the time is how do we provide good information that supplements what folks like MedStar are doing without duplicating efforts and without creating more noise. So the last thing I think that anyone wanted was kind of conflicting numbers or bad information throughout this process. So we had, our core HIE services, and I think these are pretty consistent with what you'd see in other places. And you can see they immediately translated into kind of COVID-19, and I think pretty much any emergency response efforts. So we were pushing data at the point of care. I mentioned kind of some stats that how we share data normally. We very quickly started pushing confirmed cases through the same normal mechanisms. So if a patient did show up in an emergency department, you could tell immediately they were a confirmed case previously or they had been tested. We did a lot also on the reporting side, which we'll speak to a little bit more, but I think it really emphasized the need for kind of a central group like CRISP, like an HIE, that could be a single place for reporting that could then disseminate those reports in other places. Maybe one of the best examples is that in Maryland, we worked with our emergency management group and with the Department of Health, and the hospitals submit daily, essentially census counts with PUIs, confirmed cases, ICU bed capacity, and acute bed capacity. It comes in essentially on behalf of the emergency management group, but through CRISP. And then it's published in our reports, essentially for any healthcare provider with appropriate credentials to see. And so it helps discharge planners or folks looking for beds as they try and transfer patients, but it also helps the surge planners within the Department of Health to understand, to Dr. Furlong's point, where are the hotspots? Where might there be additional needs? Do we have to work across health systems? And if so, what's the most efficient way to do it? I'll try to summarize a lot of the stuff that we're doing for COVID. We won't go through all this, but maybe I'll emphasize the emergency use cases specifically. So for example, very early on, there was an executive order so that the confirmed cases came to CRISP. We actually shared them with, it's the MIMS group, it's the Maryland Institute for Emergency Medical Services Systems. We shared it through them so that they knew if any of the EMS techs had interacted with a patient who later turned up positive, that they could kind of pull those people out of service and get them tested. We also, I mentioned the central reporting place. We in many ways also just became kind of this technology integrator for the state. So we could do some rapid cycle development to create a lab order reporting portal to drive kind of data from infusion sites and from kind of other testing capacities, and just help kind of pull things together and aggregate them again at the broader level. I like to have a couple screenshots just to show examples. These are all developed in Tableau through one of our partners. We have almost 1,000 people with access to this reporting suite, and they're checked regularly. I think another important thing Dr. Furlong mentioned was that different users require different things. And so while I might be really excited to go into a Tableau dashboard and filter and compare different counties by day to look at trends over time, if you're on the governor's team, you probably want a daily morning PDF, because you're not going to explore this stuff. You're going to look at your immediate numbers and see if they're going up or down. And so we're trying to satisfy all those different use cases, while also keeping the data flexible so we can give it to a health system so they can crunch it, they can use it locally, and they can combine it with much more precise data sets for their own uses. I wanted to dive in just to a couple more kind of discrete use cases. So I mentioned the fact that we're pushing data to the point of care. On the side of the screen here, you'll see our in-context application. This is a Fire-based app that is integrated into both Cerner and Epic systems. We're also in some of the outpatient systems, although not nearly as robustly. And this app can push care alerts on behalf of public health agencies. And so in this case, we have COVID confirmed cases and we can create a little flag. But I think having such a clear communication mechanism to healthcare providers is going to be really nice public health infrastructure in the future. I'm sure there will be countless examples where there's a certain thing that a physician needs to know, whether it's about a communicable disease or some other aspect about a patient that we could push out only to the point of care. So it only goes to the most relevant people.
Hey,
for the first time, yeah.
Jill DeGraff with Be Well Connected Health. I'm curious what thoughts you might have for adding vaccine related data now that we're moving towards maximizing vaccine administrations. If you're
very great question. So we can talk about it now, and I think I'm sure Dr. Furlong might have thoughts also. So we're working with our departments of health to get vaccine data. So in Maryland, we get essentially a daily copy of the Immunet system, or at least the COVID-related vaccines within Immunet. Right now, we're doing almost the exact same use cases that we did for COVID positives. So we're pushing weekly files to folks like MCOs so that they can receive their entire beneficiary roster. And then essentially added to that in columns, we list if a person had the first dose and what it was, lot number, location administered, then if they had the second dose and same information. One idea is that when there's more kind of availability to the vaccine and it goes beyond group 1B, that MCOs or some of these larger practices and health systems could do some really targeted outreach based on chronic conditions, age, or other things for different people. Likewise, we're pushing the vaccine data into this point of care view. And I'm not sure we've seen a ton of use with it yet, but you could see if there were vaccines given at a number of different sites, if they become much more broad, you know, a large primary care practice could check CRISP first to make sure that the vaccine second dose is the same as the first dose. We're also playing with the idea that we understand durations of time and could push out the push notifications to a primary care doctor or a care manager or an MCO if a patient is overdue for a second dose. So I do think there's a lot of opportunity there, but kind of to my first point, I also don't think we want to create noise in the system. So we're trying to be very deliberate about how we work with our state partners, how we work with health systems, so that we're not kind of just another source of data, so that we're actually working within existing data systems.
Do you expect a role for CRISP to pick up, you know, the signals from the federal government about what kind of vaccine loads will be distributed to our region on a week by week or daily basis?
No, it seems doubtful. So far, there's been, I think, very kind of clear lines of communication from the CDC and FEMA into each state, and then from the states to the health systems and the pharmacies who they're contracted with. And so it's doubtful, and that's kind of one of those examples where unless we're asked to help, you know, we try to stay out of it. If something's working, there's no need for us to insert ourselves.
Gotcha.
I guess there's debate about whether it's working, but we will approach it if asked.
Gotcha. Thank you.
Mm-hmm. Let's keep going, unless Dr. Furlong, you wanted to add anything to vaccines, or I'm not sure how different the district is.
No, I think it's about the same, and I think it is valuable information because, you know, portability is sort of all, if you sort of take it into the portability of your health record, we have different patients with different degrees of sophistication in terms of their ability to access portals, and sometimes, you know, patients, you know, just plain old forget, hey, I got my shot, I don't remember which one I got, you know, don't remember the date, and having a reliable source that crosses, you know, health systems is extremely important. And so CRISP really does serve that need well. And so you can see it having just plain old practical, you know, use right away to say, hey, you need your second shot, let's get it. And then as we start to understand, you know, more and more about this disease over time, you can see really unbelievably, you know, strong use cases for epidemiology, for studying this as we go over time, and you know, sort of correlating the, you know, immunization, you know, penetrance with, you know, peaks and troughs of the disease, and again, maybe being able to, you know, target some of those, you know, folks and populations that we want to get immunized down the road, who have not availed themselves of the opportunity when it comes. So I think, again, bringing this together is you can see it being part of a much bigger plan and be very useful for the aggregated population.
Yeah,
if I may
it's
ask
a really important point.
One quick question,
Mm-hmm.
Gary Lipsey. You touched, Doctor, you touched on health record portability. There's been a lot of conversation about patients having access to their own records. CRISP seems to be the place where everything is getting aggregated. Are there any thoughts on having patients having access to their record, so it's, you know, it's with them whenever, wherever they want or may need it?
Yeah, that's a great question. I'll speak to it from CRISP, and then I'll be interested to hear if Dr. Furlong has a different perspective.
Sure.
We, for a long time, kind of the CRISP board particularly has been considering if and how access should be given to patients for CRISP data. One of the complications is that the data within CRISP is not our data. Everything we receive is through business associate agreements or data use agreements with very specific governance. This was a little bit flipped on its head when interoperability rules came out, and they specifically cited HIEs as being subject to patient accessibility. And this past year, our board put in a goal to provide patient access to CRISP. We recently had a work group that brought in consumers and patient advocates and try to work through what is the right balance of providing data through CRISP when CRISP doesn't have clinicians and kind of the wraparound services that really drive the use of the data in an appropriate way. And so where we got, and I think the path that we're on to implementing, is that data within CRISP will be made available to patients probably hopefully around the April deadline. We're going to be really thoughtful about what data can and should be made available. It's likely to be just about all of it, but I think there's discussions around are certain labs appropriate to be delayed for a certain period because of sensitivity. But we're also, part of our policy is that the portals already existing with primary care doctors and hospitals are much more robust and a better source of data. And, so for example, if CRISP showed vaccine information to patients, that might be nice, but it'd be better if a patient went to MedStar's portal and could also schedule their vaccine appointment. And so I think it's probably more important that we work on the kind of API availability to third-party applications so that kind of the system the patient is accessing through has more robust data, but it's also a more robust system than CRISP would offer.
Will you be putting your contact information? There's something I'd like to follow up with you on separately.
Sure. Yeah, it's on the last slide, and we're glad to share these slides too.
Thank you very much.
Mm-hmm. All right, I'm going to move a little bit. I just want to highlight, I mentioned the fact that CRISP did some rapid cycle development. Because we have access to this data and because we have kind of secure solutions that are available to providers, we started doing some interesting things. We actually, kind of towards the beginning, created a universal order form so physicians could order labs for their patients. A more recent example that went live yesterday is that we have a referral form that we stood up for diabetes prevention programs as a pilot about a year ago. And we've repurposed that form so that community physicians can refer people to the antibody infusion treatments. We have, I think, 4 sites in Maryland who are using the form and 3 more that will be over the next week or 2. And it's, again, a really nice way that if you're a community physician, you can log into CRISP, which you already do for prescription drug monitoring and other clinical data, and then you can push a referral to a hospital or to one of these infusion sites in a pretty kind of standard way. We worked really hard to get nice discrete data elements and to make sure that the sites could use the data effectively as they schedule people. So I thought it's a really creative, I think, appropriate use of these portals that are pretty flexible. I want to touch a little bit more on emergency services, as that's part of the theme. So CRISP is already, as I mentioned, been working with MIMS. We actually have what we call a family reunification portal that's live in DC and Maryland, that's operated through emergency management folks. And it's a special access so that in the event of some kind of mass disaster event, the different hospitals and the first responders and other kind of appropriate users can log into CRISP and see, search for a patient and see if the patient has been hospitalized anywhere. The use case is that you call 911 or you call kind of local health department and you're looking for a family member, and the person on the other end of the phone can look in CRISP to see if they were hospitalized somewhere. That has been live for a few years. I think DC went before Maryland probably 3 years ago. But we every quarter test that. We do tabletop drills, and it's a really simple system. It's basically kind of standard CRISP tools, but we have different policies and a different user community. And hopefully we'll never use it, but in the event we have to, it's a really kind of interesting service to have available. We also have been receiving EMS data from DC, Maryland, and West Virginia. So we know when ambulance runs are made, and we can do things like show in our portal and push to care managers if a patient has been calling 911 but then not being transferred to a hospital. And that, of course, ties into a lot of population health programs and potentially even social determinants that hopefully will get even more focus once COVID is behind us. And then finally, and this part is a little more Maryland focused, but I think it is pretty broadly applicable because CRISP has all the real-time hospital feeds, the ADTs, and because we have the EMS feeds, there has been a pretty robust discussion up here about whether or not we can show kind of real-time emergency room volume and improve some of the more manual processes to show kind of which EDs are busy. Yeah, ideally, this would support kind of surgery capacity and wait time decisions. And I think it's important that we would never replace kind of actual decision-making that happens in the ED. But if there's some kind of database tool that can help inform those decisions, it could be kind of a nice way to improve some of the systems that are currently in place. And I think my last slide before I give it back to Dr. Furlong and we can open up to more questions is really a question about kind of beyond our region, how broadly available are HIEs and how much of this is transferable. And I would say first, the idea of a state designated nonprofit entity who can kind of manage multiple data feeds, protect the data, and then share it across different use cases is, I'm a little bit biased, but I think it's a really good idea. I think we've seen that, you know, if you can give the data to an HIE once and they can repurpose it and submit it to the national health surveys and different groups, it's a much more efficient way to operate. This is true certainly in Maryland, DC, and West Virginia. There are a handful of other states that have HIEs that are very similar. We're all a little bit different, but this idea that there's a nonprofit that has the robust feeds and the privacy security protections is pretty well known. We already work with all these partners. You know, when the MIMS folks, the Maryland Emergency Group, called us, we were already working on feeds for the EMS teams. And so to go one step further to talk about hospital survey reporting, you know, Andrew called me and we just talked about it. There was not a kind of new relationship being forged or new trust being built. And I think it's really important, as we've all learned over the past 10 months or so. And maybe I'll pause there on the national stuff. We can go into more detail if folks have kind of questions about states or about aspects of this, but I do think there's a lot of opportunity to use local groups to do this work and kind of build on infrastructure that is already here.
So when I put this slide together, I was thinking a little bit about just these different layers, and I'm Associate Medical Director for MedStar Transport, our flight program at MedStar, and so I kept thinking about as we go up in a helicopter, the various needs for data and the various perspectives that happen in a pandemic as you're sort of translating both the data needs, but also just the operational needs and how you see these things. And it's really important to understand those vantage points as we're planning to make sure that we're coordinated all the way up. And I think that as was noted, that something like a pandemic, something like this, a disaster, has a way of bringing people together. And if you think of that from an ER guy working in the ER to, oh, what about the rest of the hospital? And you say, oh, wait a minute, this is there's all of the different perspectives of the hospital that have to be accommodated and understood in the context of, what's going on in my world at the ER. And then in a hospital, you say, okay, what about our sister hospitals? And I mentioned that a little bit earlier about us, making MedStar one single hospital across and being able to move, patients to areas where we had capacity. Further, in different parts of this pandemic, our urgent care has become critical. We knew that we did not want to let our hospitals and our ERs and our hospitals be overrun with folks who are, appropriately worried and looking for testing when you can imagine just, I just remember early in the pandemic seeing some pictures in some of the earlier hit cities, not here, that you just saw these giant lines of patients around the corner, and you're like, oh my gosh, they're waiting, and they're not terribly sick, but they're looking for testing. Imagine how that can affect your operations, in an ED or a hospital. And so we had a little bit of an advantage of coming a few months after things started heating up in other places to prepare and to think through it. And so again, taking a little bit of a ride up, we say, what about our urgent care network? There's another 20 front doors, that we can use where we can set up, primary testing areas and add testing tents sort of along with it. Eventually, you're able to ramp up your primary care offices, and you can imagine that footprint is very, very big. And so by being able to distribute that and even go into the home at times in our home care programs, we're able to distribute what is the need of the moment in the pandemic among a very large healthcare system. And I would, put forth to a group like this to say, understanding the numbers in all of this is crucial. It is absolutely important for us to make sure that, that we see where the needs are. We can focus energy, in those directions, in those places. We can use data that's coming from, outside sources and from within to help us understand, yes, we should put a testing tent in Brandywine, okay, or we need to have something up in Bethesda because that's hot right now and there's just a large number of patients. And so really deliberately using data to help, again, coordinate care across the continuum and partner, with other health systems to be able to do that. It was really important consideration as we went through the pandemic. And I think that, again, new levels of cooperation happen. And again, it's heartening to see that happen. And so not Pollyanna, but saying, hey, really people do, drop down some barriers and recognize, hey, that everybody is in this together to make it work. I put a little vignette that I wanted to, just discuss. And as I was putting these slides together, it was actually last week, and I had just finished working a shift in the ER at Georgetown. And I had a really challenging patient, a poor fellow who lives in DC. The patient is schizophrenic, not compliant with medications, abuses alcohol and K2 continuously, is HIV positive, and has been non-compliant with his psychiatric medicines. So his, schizophrenia, for lack of a better word, was raging, and he was clearly, a patient who had much difficulty with capacity, and that patient was causing quite a stir in the ER. He was all over the place. We tried to have him keep on a mask as we were trying to evaluate, like, why are you here today? And wasn't giving really cohesive information and coherent information. What I could easily see very quickly by taking advantage of these different data systems, you're able to look and see, well, wait a minute, he's been seen in another hospital recently. Oh, 2 days ago, he was at another facility. Oh, it turns out he was COVID negative 2 days ago. Because you can imagine if a person like this is running about the ER, literally he was running about our ER, and we had to, sort of contain him. You have all of our associates, all of our staff are anxious and worried because we know that COVID is ubiquitous, and this person is yelling and coughing, and does this person, is this person, somebody who could potentially be making many, many people ill, not because he wants to, but just because he is lacking the capacity at that time. And so having that data in the moment is really important. And I think that one of the things that has been a crucial aspect of CRISP for major health systems and for hospitals is that CRISP is actually embedded. We actually pass in context from our native EHR into CRISP. And that context passing is a total game changer, so that I'm in the record of this patient at Georgetown, and I can literally click one button and I've opened up CRISP in the context of that patient, and then can see the data that has been aggregated from the patient's visits to, not just other MedStar hospitals, but other hospitals in the district or in Maryland if they were there. And so that power in the moment is really, really, really something. And again, in that particular case, you know, I was able to reassure the staff, hey, we don't know for sure, we have to take precautions, but he was COVID negative 2 days ago. And luckily, even though he had pneumonia with us and we admitted him to the hospital, he was still COVID negative. But you can imagine that kind of data element being, you know, just, you know, important, not that we drop our guard, but it really reassuring and helping us epidemiologically that we didn't all of a sudden have a whole ER full of patients who are exposed because we were frankly chasing this guy around until we could finally get him sedated to be able to you know, proceed with his care. Next slide. The pandemic, I again, without being, you know, sort of too philosophical, you really divide it into two pandemics, you know, and early on, we had new learnings going on all the time, just us understanding the disease, understanding how it's transmitted, you know, new therapies being developed, you know, oh, we think this may work, we're not sure. This, you know, ultimately coming to, you know, culmination of, you know, great progress and, you know, and therapies that we actually learned were effective. And that ultimately, you know, culminating in the vaccine. But along the way, you know, it really presented itself in such a way that the needs were different in the different phases. So very early on, it became, you know, from our government leaders, we were mandated to stop doing elective procedures. And there's a good side of that in that it suddenly gave us lots of capacity in our hospitals, in our healthcare system. The problem with that, though, is we learned that, and we really learned it as the summer went on, was that many people who probably shouldn't have deferred care were deferring care. And sadly, you could see that people, you know, across the country were dying of things like heart attacks at rates like you wouldn't expect because they were just staying home. And they were having, you know, patients and different folks having difficult times to understand what is able to be deferred, what is not. It's been a catalyst for really other areas of amazing work. You know, I would say that no question, video visits or telehealth was really smoldering in America for many years, really strapped with lots of regulations, lots of, you know, really challenges to get patients to adopt and clinicians to adopt. Well, 2 weeks after the pandemic hit, and we realized that, oh my gosh, we can't not see our patients, so we have to. And so really we're able to very rapidly, as many health systems, stand up video platforms that were scalable, that allowed us to stay in touch with our patients during this period of time. And you know, next thing you know, what's next? Well, it's the convention center. So we set up the DC Convention Center, a great collaboration, you know, with folks from several of the healthcare facilities and systems in DC, with the Army, but also with the city. Lots of agencies coming together to build, and really amazing, in the basement of the convention center, a 400-bed hospital, and stand that up. And we decided that when we were going to stand it up, we weren't going to just stand it up as a, you know, sort of place that is, you know, a bunch of tents inside a building, but we actually installed, you know, full computer systems. So we actually built a virtual second hospital. So we took Washington Hospital Center and we basically replicated it with an extra 400 beds, and we're able to scale it, you know, depending on the direction that it would go. Now, happily, you know, we never had to use the convention center in DC, but suddenly that was a way of expanding our capacity, and doing it in a way that doesn't give up on the data is really important. And I say that, you know, by keeping it in a way that we could have an electronic record, you can imagine the benefits in terms of continuity of care. And if you couple, you know, having, let's say, for instance, MedStar patients showing up and ending up in the convention center at one point in time, that's one level of benefit. But if you suddenly say, but we are connected to GW and Sidley by, you know, and Howard and by CRISP, then you can start to see, wow, you're getting a lot of good information, and you can actually really deliver the kind of care that you want to. And so again, the pandemic brought many perspectives along the way, and we're still in it. I mean, yes, we are. We've had some very encouraging, you know, most recent, you know, week or so in terms of volumes decreasing a bit around the area, but it really has been something different. Different this time in the second part as well is that we have maintained, we haven't canceled, quote, elective procedures. And so we are still doing those. And so you can imagine that that presents a greater capacity challenge for us as we go through this phase, because we have, those procedures, which again, we would maintain patients probably shouldn't have been deferring along the way. We're continuing to be able to do those. And so we're very, very lucky that as testing has evolved and as we have become, for lack of a better word, quote, better at managing these populations and managing them in the, the kinds of spaces that we have been able to maintain, procedures and quote, normal care, we're calling it, along with those folks who need our help for COVID. Next slide. I think, one, just to jump in again, back on the capacity item, it's really important to appreciate that capacity isn't just your licensed beds. It's not just that you have X number of beds licensed by the district or by Maryland, and that's what you have, and you can automatically assume that those are usable. Further complicating things, we realized that as we needed to increase our capacity, that we had to open and repurpose spaces. So things that had maybe previously not been used in the way we're using it, we did that. And we did it both, in hospitals and again, looking at our overall outpatient footprint as well. And everybody did that. And so that's, important consideration. Another side of this was, what kind of bed is a good bed, to care for a patient with a potentially infectious disease and negative pressure, whereby you draw air into a room and you blow it outside or blow it out through filtering systems is a really important consideration to reduce the spread of infection or potential spread of infection within a hospital. And so we literally converted large, towers of our hospitals into negative pressure suites where, entire buildings were negative pressure, and units were able to expand our capacity for those patients who need that kind of isolation. That immediately helps to bring another level of protection to our associates, but to the other patients. We're a transplant center at Georgetown, for instance, and you can imagine the immunocompromised patients where we're caring for them and needing to very, very carefully, keep them separate from, somebody who may have an infectious disease that could, be a fatal complication for somebody who's immunosuppressed due to a transplant. You can imagine cancer patients, people with other diseases, autoimmune diseases, or HIV or AIDS, who also could be a more vulnerable population. And so by thinking of our capacity, not just in terms of a bed, but, in terms of the overall spaces, it's really important. In addition, also you think about the equipment, what you need to care for a patient, and that can be from simple basic things like beds and sheets and care spaces to things like oxygen, and cleaning materials. How do you keep it clean? How do you clean it each time, multiple times? How do you have all those kind of pieces? Those are all part of our capacity. And then you get into other measurable things like ventilators, or even super specialized things that we do, at Hopkins and Maryland and at the hospital center, things like ECMO, where you can, where you have literally 5 or 6 of those kind of patients at a time in an institution, very specialized equipment, but it's all part of capacity. Of course, you have to have the PPE, and you really have to redesign your flow as you do this. And never, ever forget, the critical part of our capacity is the people. Nurses have been in unbelievable demand, during this pandemic, and we have repurposed folks, within institutions and across. Folks have repurposed things. Whenever things shut down on the outpatient side, whenever certain offices were closed, we moved all of those folks into different roles and made sure they were trained up to be able to care for patients safely, but really changed models of nursing and really looked at, how we could utilize everybody to help, because it's all part of the capacity to not be overrun, to be able to care for patients. Another consideration, just to throw it out there for folks, is that these COVID patients, they take a lot of time to get better. So whereas you may have other illness categories where we have hospital length of stay for a couple of days, things of that sort, where you can really, with intensive care, get somebody turned around quickly, a lot of these COVID patients really have a hard time being transitioned out of the hospital. And so though we have become better at it during the pandemic, better at getting people oxygen at home, using home monitoring, things of that sort, as they were in the latter parts of a hospital stay, they, generally speaking, have very long lengths of stay. And that length of stay immediately, compresses your capacity, because because it's instead of a new patient coming in every couple of days, that one patient is staying, and so has to be considered as you go through it. Again, I talked about deployment. It applied not just to nurses, but also to our physicians and other kinds of caregivers and associates who help out. And then finally, you think about the impact of COVID itself. That very luckily we've had a relatively small number of healthcare workers get COVID. Most who've gotten COVID have gotten it from community spread, and really very uncommon that you have any patient to healthcare worker transmission. But once those folks go out, that further compresses your people, and it makes it, and especially if you have any exposures, you have to isolate your associates, you have to move them out of patient care areas. And so all those are considerations when you have capacity. And so as we went back to sort of the beginning, when we're talking about the data that we have, all of these factors you keep track of, and you have to keep track of them at different levels. And all of those help us understand where potential vulnerabilities are coming and allow us to redeploy and to carefully manage those, again, based on data, not just on what you're seeing in the moment. Next slide.
Brendan?
Yes.
Yeah, just on that previous topic on the previous slide, when you try and send a patient home, I mean, we know we have more of the telemedicine now.
Yes.
But are there new kinds of processes, maybe with community healthcare workers or social workers or other people in the home, to maybe try and support these COVID patients better? Because this is going to be something that maybe a family member may have a tough time doing. I mean, you're used to caring for a kid with the flu every year or a broken arm, but this is new for a family member. So there's that aspect. And if that's going on, then for Craig, is there a way that this data in the home and this care in the home can be better sucked in or absorbed into CRISP or maybe into the EHR so that we don't lose track of this? And then finally, on top of all that, is there a way to keep track of this data so that actually research can be done? So even though you guys are doing a great job, California can benefit from it. So it's kind of a multi-tiered question on that care transition and care in the home.
Yeah, I would say just the continuum of care is definitely involves the home now. And so that whereas when we had the first index case in DC got admitted to Georgetown, the length of stay was long because nobody was quite sure just what direction these patients were going to go. Now we're actually able to send patients home, and we send them home and we stay in touch with them in many ways. So we have, in addition to the ability to do, calls or video check-ins with patients, we also do remote patient monitoring. So we can send them home with pulse oximeters, and we're able to watch and see, and have alarms and things of that sort to go off to say, hey, wait a minute, their oxygen saturation is dipping a bit. We need to check in with that patient. So it can be both an active and passive process. In terms of chronicling the information, we record that as a health system. We record it in our EHR. And so we sort of extend that on as visits. So it becomes part of the overall data picture of that patient. So we are better able to do that. And I think you touched on something really important also about when we send patients home, we have to make sure that family members understand how to safely care for that patient, but also for themselves, right? Because you have somebody who at some level could be viral shedding and could be, infectious at that point, coming back into that environment. And so, there's no way to just take people away forever until they're totally asymptomatic and they would have no chance of passing a virus to another person. And so really making sure that families, when they receive family members back at home, have the tools they need and understand, the safest way to help care for their loved ones. So really important that way.
Yep. I think just a note on the kind of HIE use case here. I think it is kind of up to the health system to record the patient information, the visits, they work within the EHR. I think the interesting thing for the HIE is, if we can share with, other providers the fact that the patient was sent home with those discharge instructions and is kind of being actively monitored, then if the patient did have some kind of event and go to a different hospital or to an urgent care, then, they could maybe point back to the team at MedStar and make sure that there's some continuity. And so that's actually where I kind of focus on the care team and who's currently working with the patient as a really important role for the HIE.
Can I just ask a question on capacity, Brendan? I'm curious to know if you think that that continued challenge of capacity, particularly as I think you referenced, you know, the decline in treatment of other conditions, you know, people not showing up for care. Is this a continuing problem? What's the sort of status of that? And I ask with a vested interest as a foreign medical graduate that has no right to touch patients in this country. You know, I'm frustrated sitting on the bench if that's the case.
Sure. What I would say is that in our region right now, I feel pretty good. You know, we have capacity. I would say, you know, we got pretty tight about 2 weeks ago in terms of, you know, having, you know, small numbers of ICU beds available. And I speak to MedStar because that's what I know, but I know that the other systems are very, very similar in that, you know, we had it down to like, we have 7 ICU beds left in the system that are not occupied and are fully staffed and ready to care for a patient versus, you know, other times where we have greater capacities. And so with that, you know, as we study that and we see where we are, we know that we have other things we can do, you know, in terms of converting more spaces, changing things, but we have to get that on that capacity slide, make sure we're accounting for all those other pieces of it, as you know, to make sure we're there. So again, I don't want to jinx us, but our curves, if you looked at the curves of our total capacity that we see every day, we've been on about a 5-day to 6-day downward trend of capacity, meaning we have less patients in the hospital with COVID specifically, and that the hospitals themselves have been doing well now. And so we're good right now, no question. Guarded about what's going to be next week, but hopefully this is the beginning, you know, with the hopeful immunization, and again, over time, hopefully the overall incidence and new cases will just decline.
So I think, you know, this is kind of a wrap-up summary slide, and the next one's our contact and resources. So maybe I'll just highlight, you know, some of the reasons that we think this region has been very prepared and the way in which the HIE was helpful. But, you know, more than happy to open up for questions also. And so I think what you've seen as a common theme is that kind of having the data in real time as possible in accessible ways to help the decision makers, help the Dr. Furlongs of the world kind of understand their capacity in relationship to other hospitals' capacity, understand kind of the trend of the disease over time is obviously vital. And I think the HIE has a role to play, although we're certainly not the only group doing this work. We also have a lot of reusable technology. So as we push out information, we can do it through existing portals, not creating secondary workflows. We're trying to do something unique. And then I think just kind of the trust factor, the fact that we already have the privacy security framework, that we already have partners of the state agencies and the healthcare community, has just been really important as people ask our ideas and ask us to lean in on different things. And you know, they trust, I think, our honest assessment about what we think the HIE can be helpful for, and maybe what we can't be helpful for, because there are better groups to do it. But maybe with that, I'll pause, and unless Dr. Furlong has any kind of wrap-up thoughts, we can open up to questions.
No, just thanks again for having us and welcoming us to the forum, and happy to answer questions if any of y'all have some. Great.
I'm gonna just ask what I asked a little bit before, but we didn't get the answer to it then. The opportunity for research, either working with, you know, Georgetown or MedStar, or versus, you know, aggregated data, you know, at CRISP. What are those opportunities for research, and why? And we saw some of the reasons why this region was better prepared, but it's kind of surprising, you know, California is a state with so much resources. Why is it that California was in such bad shape 3 months ago when we're doing pretty good here? Or was 3 months ago a lifetime ago, and now everyone all over the country is jamming? What's, you know, so research and best practices sharing are the two questions I have.
Yeah, I'm embarrassed to tell you, I don't remember how many studies we have going right now in terms of clinical trials. We have tons, going on, and in collaboration with, obviously many agencies, whether it's, looking at remdesivir, whether it's monoclonals, whether it's all the different. So there's, I would call it sort of medical sort of research going on for sure. And then, epidemiologic research and these kind of system-based learnings as well are very, sort of rich areas. So, no, I would say absolutely, folks are open to collaboration and to work on that. I don't know for sure, and I don't want to misspeak, but I don't know enough about like the root causes of the challenges in California to be able to speak to them. But there's definitely, sort of on a positive note, a degree of cooperation. What can't be understated is the importance of the cooperation of the governors of Virginia and Maryland and the mayor in DC, having jurisdictions sort of going in the same direction. And generally, they're not exactly the same in each place, but this general like dialogue, because we're so interrelated, is very important. And you can see in many places that breaks down when you have different agencies and different, governing groups that may not have that degree of, coordination. And so I think that coordination has been a really important piece of, us moving together in a direction that generally helps people keep it a little bit more in check around here.
Yep. And I think that's also true at the hospital level. We have the hospital systems are meeting regularly. I'm sure Dr. Furlong meets with his colleagues regularly. Our hospital associations are in constant contact with everybody. And so I do commend the amount of collaboration that happens among competitors, because in this case, there really aren't any competitors.
This is a question for both Brendan and Craig. I'm curious, for many of you here, you already know the funding model for HIEs generally and CRISP in particular, but I'm just kind of curious if you could provide kind of a history of the funding model and whether that model seems to be sustainable today or if you have some headwinds.
Sure. So CRISP was founded about 12 years ago. It was kind of a partnership of MedStar, Johns Hopkins, University of Maryland Medical System, and Erickson Retirement Communities. And the original use case being that John Erickson was frustrated that his residents would come home and he'd have no clue why or what they were given or what those people in the hospital did to them. And there was a grant that was put up by Erickson that was matched by the state. And but soon thereafter, once we became established, we essentially have three primary funding sources. The first is participation fees. Those are paid by hospitals and carriers. We then have state funds. In Maryland, this is primarily because of our unique payment model through the Health Services Cost Review Commission. But in places like DC, there are also local grants provided. And then we receive a lot of federal funds through Medicaid and the different kind of advanced planning document programs. I think, our kind of overarching philosophy is so long as we're efficient and providing value, that our sustainability should be pretty clear. If we can provide helpful data in context, I'm confident that MedStar will pay participation fees as long as those fees are kind of commensurate with the value. And I do think the federal programs, the more we can do to leverage federal dollars and become reusable and spread things across states, I think the kind of fewer headwinds we'll experience. So it's not perfect, but I think we're in good shape, and I think it's a very replicable model. Many other states have very similar kind of funding strategies.
Yeah, and I would agree. And I think that, even though you think of it as like healthcare, really we're reaching out, as Craig mentioned, into other areas of social determinants, absenteeism from school, things of that sort, things that are really important to get at the base of, which really, so DC Health is, helping to fund, work that we're doing in that direction, doing things like lead testing, things, things that you would, yes, they're sort of medical, but they're also, preventative care, but they're also looking at some of those other challenges that we see in this society, really making sure that mental health services are coordinated in, through the HIE have been really important hallmarks. And to me, what those say is those bring value, and those bring value beyond healthcare. And I think as long as we, as CRISP, can continue to demonstrate value, as Craig said, then those fundings will continue.
Great. Do we have any other questions from anybody? Well, this was absolutely fantastic. Nick's going to be putting up the Zoom of this, which is great, and we have the slides to share as well. There was just a ton of wonderful information here, so we really want to thank you for that. And I'll put in a plug that I think one of our sessions coming up, Jim, in about 4 or 5 months is going to be on a topic you touched on, Brendan. So maybe we can even get a heads up on a speaker for 4 or 5 months from now on this topic of COVID long haulers and delayed care, and how the care landscape is changing in that regard. So if you think of someone you want to recommend, while it's fresh in your head, for someone in a session around 4 months, in that very deep dive, we'd be happy to hear about that person as a potential panelist as well. Otherwise, on behalf of Jim and Nick and David Main, who's the partner at Nelson Mullins Law Firm, who's a sponsor of this event, just really want to thank you. And I don't know, Jim, Nick, do you have any closing words or thoughts or logistics?
No, thank you very much. Great presentation. I would just say, if you're offering an expert in COVID long haulers, we obviously seek somebody that has at least 2 years experience in that particular area of clinical challenge. I jest, I'm sorry. We know so little, so I'm excited to hear if you've got anybody that has insights, because clearly emerging problem. But no, outstanding, Craig. Good to see you and hear some more, and some practical applications of the HIE. God, let's hope that that's actually going to accelerate widespread adoption of these kind of technologies that clearly make sense for a whole slew of reasons around clinical coordination.
Jim, any final words?
Just absolutely outstanding. I feel like I learned a lot. I think we all did. I really appreciate it. Again, Dr. Furlong, Craig, thank you so much. Richard, again, thanks for putting all this together. And Nick, as always, thanks so much for being our host. So good day, everybody. Have a good weekend. Stay safe. And we will see you next month.